Okay. Chapter 44 is acute disorder of brain function. Okay, traumatic brain injury occurs as a direct result of the initial insult. Secondary injury refers to progressive damage resulting from the body physiologic response to the initial insult. Clinical factor in determining the neuronal cell fate after injury, degree of adenosine triphosphate depletion. Ischemia and hypoxemia. Ischemia, you already know that is a decrease of blood flow. Contribution factor either as the primary insult or a part of the secondary response. Ischemia results in immediate neurological dysfunction because of inability of the neuron to generate ATP, which is the energy of the body. Ischemia and hypoxemia, decrease of oxygen at the cellular level, usually occur together. Ischemia, remember that ischemia is the lack of oxygen, the lack of blood supply, and hypoxemia is the lack of oxygen. Cellular energy failure. Neuronal tissue highly sensitive to oxygen deprivation have great ATP requirement and limit capacity for anaerobic metabolism during ischemia. Depend on glucose for ATP production. Store very little glycogen, about 5 to 10 minutes without oxygen, irreversible brain damage. That's why the brain, if you have an stroke, produce a lot of sign and symptom because brain always need oxygen. It's not like other tissue that could be like for 1 hour without oxygen and don't have any problem, but the brain always need oxygen. Two mechanisms can cause brain cell death: anaerobic metabolism and deterioration in ion gradient. Anaerobic metabolism causes mitochondrial dysfunctions. Anaerobic glycolytic pathways are initiated. Pyruvate convert to lactate. Hydrogen ions lead to cellular acidosis, which affect neuronal integrity. Inadequate energy supply leads to the deterioration of ion gradients. Anoxic depolarizations cause potassium to leave the cell and sodium chloride and calcium ions to enter, leading to injury and death. That's the physiology of cellular injury. Excitatory amino acid. Excessive glutamate excitatory may be released because of impaired membrane integrity. Normally is an excitatory amino acid neurotransmitter important in learning memory. Okay, let's keep going. Reuptake mechanisms fail to remove excessive glutamate because they are energy-dependent process. Glutamate is a neurotransmitter. Okay. Excitatory amino acid excessive glutamate stimulate nerve neurons that then take up large amount of injury, causing overload injury. NMDA receptor activate stimulate nitric oxide production in neurons. In excess, it may increase production of reactive nitrogen species that functions as free radical to damage cellular components. This neurotransmitter, not only in like brain injury, also there are diseases that neurotransmitter produce a lot of damage. Hyperfusion injury. This reperfusion injury is the same like in any part of your body, like in the heart, okay? When oxygen enters the cell, it can produce reactive oxygen production that behave a free radical. Remember that oxygen is a free radical. Hydroxide radical, superoxide, and peroxide. Cell membrane may undergo lipid oxidations with subsequent formation of arachidonic acid. Arachidonic acid cascade yield more oxygen-free radical and mediator of inflammation, compounding the problem. Normal autoregulation. Normal provide a steady supply of oxygen and nutrients to brain cells and remove metabolic waste. Normally influenced by pH, carbon dioxide, and oxygen in the arterial blood. Injury causes imbalance, local or global impairment. Anything that interferes with vessel dilation leads to ischemia. Impaired vasoconstriction mechanisms cause hypoperfusion and edema formation. Remember that if you have vasodilations, there is blood pooling in the venous, and that decreases the blood flow, and as a consequence, then you have ischemia and hypoxemia. Increase intracranial pressure, volume of cranium composed of three elements: brain tissue, cerebrospinal fluid, blood. Normal intracranial pressure from 0 to 15. Model kill hypothesis. Compensatory response to change in volume in any of these components. Increased intracranial pressure can occur with space-open lesions like a tumor, vasogenic or cytotoxic edema, with obstruction or excessive production of CSF, that is hydrocephalus. Increasing intracranial pressure, clinical manifestation, headache, vomit, altered level of consciousness, blurry visions, and edema. This of the OTDs, that is papilledema, that's one of the most common signs and symptoms of intracranial pressure, papilledema. As intracranial pressure rises to higher level of consciousness decrease, pupil responsiveness to light becomes impaired, altered respiratory pattern, and unresponsive to stimulation, unable to move, verbalize or eyes or opening of the eyes. Brain compression and herniation. As intracranial pressure rises, it can compress neural tissue and blood vessels. Herniation, protrusion of brain tissue through an opening in the supporting dura of the brain. Depthly. A type of herniation syndrome, subfasciic, tentorial, buccal, and tonsillar. That's why intracranial pressure is an emergency, and we have to take care of the intracranial pressure, because you have the herniation that is not compatible with life, and the patient is gonna die. Management typical based on diagnostic brain image, CT or MRI, may be managed surgical or medically. Intracranial pressure and cerebral perfusion pressure measure, remove of lesion or CSF. Treatment focus on management cerebral oxygenation. You have to be very careful with intracranial pressure, because if you have a lot of fluid, uh, and if you make like a tap on the spinal cord and you take off the fluid, that can produce a herniation. That's why it's a little bit complicated, the management of intracranial pressure. Level of consciousness. Change in level of consciousness is most sensitive indicator of altered brain functions, state of alertness, and attentiveness to one's environment and situations, depend on activity in the RAS neurons. Level of consciousness may fluctuate, important to monitor and treat changes. loss of consciousness is a coma. Glasgow, Glasgow Coma Scale is how you measure the level of consciousness in medicine. Okay, standardized tool for assessing level of consciousness in acute active brain injury persons. The numeric score gives the arousal direct responses, eyes opening, verbal utterances, motor reactions. Mild, more than 12, moderate 9 to 12, and severe, less than 8. When you have a patient with less than 8, most of the time you have to intubate the patient. Motor response, most powerful predictor of patient outcomes. Uh, the cortical point, a normal flexor. The cerebrae posturing, a normal extension. That scale go from 0 to 15. 15 is the highest number. And right here we have question number 1. Okay, what will be the Glasgow Coma Scale value for a patient who opened his eye when the nurse called his name, does not know where he is or that is nighttime, and purposeful movement his head away when the nurse applied pressure to his brow bridge? What is the answer? Okay, in order to know the answer right here is more complicated because then you have to know the whole Glasgow Coma Scale, and that goes by number. We have the eyes, the motor, the movement, and but in this case the answer is C, 12. Okay, this patient is 12, which is moderate. We have question 2. A patient's posturing is characterized by a normal flexion of the arm and wrist with the leg and feet extended and internally rotated. How will the nurse chart this finding? Okay, the answer right here is B. Remember that we have the corticae and the cerebrae, okay? When you have flexions is the corticae, and when you have extension is the cerebrae. Now, manifestation of brain injury, we have pupil reflex indicate the function of brain stem and cranial nerve number 2 and 3. Changes in size, shape, and reactive of the pupil early indicate of intracranial pressure and possible brain herniation. Eye movement controlled by cranial nerve number 3 and 4 and 6 may be impaired with increased ICP intracranial pressure. Nystagmus, disconjugate movement, and ocular pulses may be present. Nystagmus is when you have we have vertical or horizontal nystagmus. It's like movement of the eye. Oculovesicular reflex, reflex imply brain stain dysfunctions. Certain medication can depress this response. Those eyes maneuver entail rotating the patient head from side to side. Normal eyes turn in position direct to the head rotation. Or caloric inject cold water into the ear. Normal response, denervation of the eyes toward the side of the irrigated. All those reflexes is to see if the brain stem is functioning, okay? Because if you don't have brain stem functioning, the patient is not in coma, okay? The patient is brain dead, the famous brain dead. Because coma is that you have the level of consciousness of the patient is low. That basically what means coma. Okay, you have the brain reflexes present, but the level of consciousness is low. Is a patient in coma. Those patients is a patient, you give the medication and that body responds good to the medication, that patient go back to life because that is possible. But if the patient doesn't have any brainstem reflex, that means that the patient is brain dead and there is no going back to life. Okay, once you are brain dead, that's it. Okay, you could keep that body alive because it's connected to the machine, but that body is not gonna go back to the life again. That is a terrible situation, not only for the family, also for the medical staff, okay? Especially the nurses. Sometimes have to deliver the new to the relative. Okay, we have corneal reflexes, with of cotton touches cornea of the eyes to elicit a blink response. Absence of blink response indicates of severe impaired brain functioning. Traumatic brain injury leading cause of death and disability in the United States. Most head injury incurred in transportation-related accidents, fall, firearm, and sport accidents. Severity of traumatic brain injury is classified by the Glasgow Coma Scale as mild, moderate, and severe. Type of traumatic brain injury, we have primary injury, focal, polar, diffuse, intracranial hematomas. We have epidural, subdural, and subarachnoid. Primary injury resolve initial trauma, injury of the brain cell, focal injury, localized to site of or injury is a counter caused by acceleration deceleration movement of the brain within the skull, resulting in double injury, usually opposite focal injury, that is sometimes in when you have a concussion. Okay? Diffuse injury caused by movement of the brain within the skull, resulting in widespread axonal injury. Primary injury, mechanism of injury, concussion, mild traumatic brain injury, most common injury encountered by military person and athlete, special football player, alteration of loss of consciousness, less than 10 minutes, but no evidence of brain damage on CT. Headache, nausea, vomiting, dizziness, fatigue, blurry vision, cognitive and emotional disturbance. Contusions, CT or MRI reveal an area of brain tissue damage, necrosis, laceration, bruising, intracranial hematoma, localized collection of blood within the cranium. Intracranial hematomas, we have disruption of the vascular can result in intracranial hemorrhage, may expand slowly or that's according to the vessel that is damaged. Progressive compression brain structure and increase intracranial pressure. We have epidural, subdural, and subarachnoid. Epidural is a collection of blood between dura and skull, typically involve arterial injury, thus rapid onset of symptom manifestation. Primary injury is minor, may suffer only a brief period of disturbance consciousness followed by a period of normal cognitive lucid interval, then consciousness rapidly deteriorate and most of the time patient die. And diagnosis CT non-trust. Okay? You have to be I think for the class, CT scan, okay. Real life CT scan without contrast. That's the real test, okay? We have with contrast and without contrast. Treatment surgery to remove hematoma. CT scan without contrast is the first test that you perform in any brain damage, okay? Including a stroke, because that is to see if there is any blood. Subdural hematoma is a collection of blood between the dura and the outer layer of the arachnoid membrane, typically involved bridges vein. Epidural hematoma involve the arteries. Okay? Subdural involve the bridges veins. Symptom onset may be slower, acute symptom within the 24 hours of injury, subacute, increased intracranial pressure, headache, vomiting, vision, 2 to 10 days later, chronic response to rebleeding. Diagnosis: CT and MRI. Treatment: remove tissue and clot. Subdural have presentation, okay? The acute and the chronic. The acute is like immediately in the first day. The chronic is more like, the subacute is more like slowly. That's why sometimes, especially in the elderly population, when they have a head trauma, they are normal, but you have to go to the doctor to take an image because if you damage the bridges veins, those veins, the bleeding is really slow, and then maybe 2 3 days later, the patient start developing signs and symptoms. Subarachnoid hemorrhage, collection of blood between a membrane and the pia mater, caused by rupture of bridges veins that pass through the subarachnoid space, more commonly associated with rupture of cerebral aneurysm, venous malformation, in origins, blood spread throughout CSF, causing meningeal irritation, hydrocephalus, vasospasm, and ischemia. Secondary injury: body response to initial injury may cause more harm than the initial injury. Can cause ischemia, hypoxic event, vasogenic neurogenic edema, and other processes that lead to brain swellings and increased intracranial pressure. Concomitant trauma may implicate brain injury. Ruptured vessel may rebleed or expand, and CSF drainage can become clotted. Treatment: cardiopulmonary stabilizations, radiologic screening to evaluate need for urgent surgical management, maintain normal body temperature or mild hypothermia, normal CO2, normal serum glucose level. Glucose level is extremely important because high glucose level is an indicator of worse condition. A normal intracranial volume recommended. Likely elevated intracranial pressure, administration of mannitol, that's a diuretic, sedation, hypothermia, and mild hypertension. Treatment: severely high intracranial pressure, more aggressive measurement, diuretic, hypersaline, moderate hyperventilation, and barbiturate coma. Open head injury, prophylactic antibiotic, Bates skull fracture, CSF can seep out of air fluid from the ears or nose, bilateral periorbital hematomas, and bruising under the ear. Those are signs of uh, intracranial bleeding and skull fracture. Especially you have a patient that have a head trauma and they have like runny nose. If you have a severe head trauma and the patient start having runny nose, be careful because maybe that CSF, because CSF is extremely similar to runny nose. Epidemiology causes abnormality of cerebral perfusions, transient ischemic attack, TIA, ischemic stroke, and hemorrhagic stroke. Stroke, the sudden onset of neurological dysfunctions caused by cardiovascular disease that result in area of a brain infarction. Stroke is the fifth leading cause of death in the United States. The most common form of stroke is ischemic, and it's the of the two because we have hemorrhagic and ischemic. The worst is hemorrhagic because there is basically there is no treatment for hemorrhage. Epidemiology: males affect more often than females. Risk factors are similar to those for other atherosclerotic vascular disease, hypertension, diabetes, hyperlipidemia, smoking, advanced age, family history. Ischemic stroke results from sudden occlusion of cerebral artery, secondary to thrombus formation or emboli. Thrombotic stroke associated with arteriosclerosis and coagulopathy. Embolic stroke associated with cardiac dysfunction and dysrhythmia. Atrial fibrillation, especially atrial fibrillation. Clinical manifestation: contralateral hemiplegia, hemisensory loss, and contralateral vision field blindness. The most common sign and symptom is contralateral hemiplegia. Okay? Treatment: salvaging the penumbra is the aim of early thrombotic therapy. However, treatment must be instituted within 3 hours of symptom onset to be maximally effective. This is really hard because sometimes patients that have ischemic stroke, you find the patient maybe lay down on the floor, and in order to meet that criteria, that is 3 hours, is the last time that the patient was normal, not the last time that you saw the patient maybe on the floor, because maybe the patient was on the floor for like 10 hours. That's why it's really hard to meet that criteria of 3 hours. Okay. Question number 3. Okay, a nurse is asked about the definition for penumbra. How should the nurse reply? Who knows the answer? Okay, the answer is B. Okay, penumbra is the cells that are surrounding the area that is ischemic. Okay, and that's your target treatment, your main treatment. Okay, it's basically to recover those cells. Okay, that's why you have to work really fast to refuse that area. Neurologic deficits completely resolved. Transient ischemic attack. A transient ischemic attack is neurologic symptoms typically last only minutes, but they may last as long as 24 hours. Okay, the real definition for transient ischemic attack is an ischemic attack that resolves in the first 24 hours. Okay, most of the time those patients recover in the first hour. Symptoms resolve completely without evidence of neurological dysfunctions. TIA are important warning signs of thrombotic disease, carry a significant risk for subsequent stroke. Treatment: daily aspirin, carotid endarterectomy, or angioplasty is 70% occluded. Hemorrhagic stroke within the brain parenchyma usually occurs secondary to severe chronic hypertension. Most occur in the basal ganglia and thalamus. Is the same as ischemic stroke. Those are the most common areas. Degree of secondary injury, associated morbidity and mortality is much higher in hemorrhagic stroke than ischemic stroke. Cardiovascular stabilization, CT determine type and location, intracranial pressure monitoring, management, ischemic stroke, treatment in minimizing infarct size and preserving neurological functions, thrombolytics, anticoagulants, antiplatelets, endarterectomy, angioplasty stents, hemorrhagic stroke, blood pressure management, treat mild hypertensive at first. That's extremely important. When you have a stroke, you have permissive hypertension. Okay? Motor sensory deficit. Initially, motor deficits occur as a flaccidity or paralysis. Recovery of motor function occurs with onset of spasticity. Contralateral, the side of the brain where the stroke occurred. Active range of motion. Excessive shoulder should be started in adequate phase of recovery. Elevate edematous limbs. Use elastic stocking and maintain body alignment. Aggressive rehabilitation commonly required. Motor and sensory deficit. Sensory disturbance occur in same location as motor paralysis and may involve neglect or visual impairment. Loss of vision field of the paralyzed size also contribute to neglect. Contralateral field blindness, homonymous hemianopia, the sense of the retina, each eye is blind. Access for wrist, that's extremely important. Always, you as a nurse, you have to take care of this. Okay? Language deficits, aphasia occur with brain damage to the dominant cerebral hemisphere and can involve all language modalities. This dominant side is on the left side. Okay? Broca aphasia, Wernicke aphasia. Broca aphasia is a verbal motor expression, consists of pure articulation and sparse vocabulary. Wernicke aphasia is sensory acoustic responsiveness characterized by auditory comprehensive and speech that is fluent but does not make sense. Okay? Broca aphasia is broken boca. Boca means mouth in Spanish. That's why those people with broken boca, they can't speak. In Wernicke is what? What? Because they speak but they don't understand. Cognitive deficit area of brain affect the dictate presence and severity of cognitive impairments, evidence as language impairment, impaired spatial relationship skill and short-term memory, and poor judgment, concentration, memory, and reasoning may be impaired, may require rehabilitation, severe, but in some cases it may not be beneficial. Cerebral aneurysm and arteriovenous malformations, a structural anomaly of the cerebral artery predisposed to intracerebral bleeding and hemorrhage. Cerebral aneurysm and arteriovenous malformation are the most common cause of subdural hemorrhage. Arteriovenous malformation is common in pediatric population. Lesion artery that results in dilation and ballooning of segment of the vessel, high blood pressure, acute alcoholism, alcohol intoxication, and recreational drug use, especially cocaine. Cocaine is related with cerebral aneurysm and myocardial infarction. Congenital defect of the middle layer of the artery, weakness allowing the dilated portion to fill with blood and eventually burst, causing hemorrhage, most found in circle of Willis, especially in the anterior communicating area of the circle of Willis. Clinical manifestations typically present in severe HA meningismus. Meningismus is that you have those symptoms, photophobia and neck stiffness. Okay. Um, Diagnosis: CT, MRI, lumbar puncture. You have to be very careful with lumbar puncture. Okay. You have increased intracranial pressure in adult population. Lumbar puncture is contraindicated. Treatment: surgical stabilization with aneurysm, clippings, clipping or embolizations. Vasospasm management by keeping blood volume pressure at normal to high level and calcium channel blocker. Especially calcium channel blocker, because calcium channel blocker is gonna prevent the vasospasm. Okay? Capillary system failed to develop appropriately with arterial blood shunting directly into the venous systems, cause the vessels to progressively enlarge, becomes an congested mass, an enlarged vessel that can burst. Clinical manifestations: seizure and neurological dysfunction. Treatment: surgical removal, gamma knife, stereoactive radiosurgery, irradiation, or glue embolization. Central nervous system infections. Organisms may gain access to the CNS through the bloodstream, direct extension from the primary site, or along peripheral and cranial nerve, or through maternal-fetal exchange. Risk factor: immunocompromise, debilitation, poor nutrition, radiation, steroid therapy, contact with vectors, meningitis, and cerebral accesses commonly associated with bacterial infection. Encephalitis, usually viral. Meningitis: bacteria usually reach the CNS via the bloodstream or extension from cranial structure like sinus or ears. Most common bacteria are Streptococcus pneumoniae. Bacteria invade the meninges, accumulate of inflammation exudate, can result in obstructive hydrocephalus. Meningitis classic presentation: headache, fever, neck stiffness, that is meningismus, sign of cerebral dysfunction, confusion, and delirium. Diagnosis: lumbar puncture. Remember, lumbar puncture if you don't have increased intracranial pressure. If you have increased intracranial pressure, you have to do a CT scan or MRI. Treatment: intravenous antibiotic therapy and supportive measurement. Corticosteroid is controversial. Corticosteroid is controversial, but corticosteroid is gonna help with the inflammation of the brain. Preventions: vaccines, we have HIV and meningitis. Encephalitis, inflammation of the brain, commonly caused by West Nile virus, Western encephalitis, and herpes simplex. The most common one, herpes simplex. Typically presentation of West Nile yellow fever, headache, malaise, muscle pain, and rash. For herpes, fever, headache, seizure, confusion, stupor, and coma. Diagnosis: CT, MRI, or lumbar puncture. Treatment: support control of symptoms, including antipyretic, antiviral, steroid, anti-seizure, and fluid resuscitation. Brain accesses: localized collection of within the brain parenchyma, usually from post-formation bacteria pathogeny, present as space-occupying lesions and typically with signs of infectious etiology. The most common sign and symptom of brain abscess is motor deficit. Treatment, drainage or excision of the abscess with IV antibiotic. And right here you have a case. This case is for all of you to study in the PowerPoint that I'm gonna put all those PowerPoint uh, on the blackboard. You have all the answers. Okay, those case is for you to study, review. If you have any question about those case, just send me email or remind me, and I answer all the questions for you. But those answers are for you to study. Now, let's go to the we already got chapter 44. Now we go to chapter 45. Okay. Any question about this chapter? About chapter 44? No question? No? Hello? Can you hear me?
Yes, we can.
Yes, okay, perfect. Okay, you don't have any question. Let's go to the next chapter, okay? Okay, chapter 45 is chronic disorder of neurologic function. Okay, listen, this is week number 8, and in week number 8 we are gonna be covering 44, 45, 47, and I think 51 and 52. Those are the last chapter that we are gonna cover in the whole semester, okay? And today, okay, Susana, okay, listen, today I'm going to put the final review, okay? Final review, you have to get the review from the midterm because that all that information is gonna show up right here in the final, plus one Word document that I'm going to upload today, and right there you have the whole review for the final. Remember that the final is cumulative, okay? It's everything from chapter 1 to the last chapter, okay? So today I'm gonna put the final review that you start like, reviewing, preparing, because next week we have the final. And for the student, I know that right here there is just 3 students, but your classmate, I'm sending emails, sending reminding app, everything. If you are missing any assignment, anything during the whole semester, it's gonna be open until next week. Okay? And I encourage that you go and finish everything, because if you don't finish by the next week, then you get a 0 and maybe you get in trouble with the class. Let's go. Chronic disorder of neurologic function. We have seizure disorder, dementia, Parkinson's disease, cerebral palsy, hydrocephalus, and cerebellar disorder. Seizure disorder is transient neurologic events of paroxysmal abnormal of excessive cortical electric discharge, manifest by disturbance of skeletal motor function, sensation, visceral function, behavioral, and consciousness. Epilepsy or seizures disorder refer to recurrent seizure. Okay? Seizure is just one event. Epilepsy means that you have several events of seizures. Okay? Cause cerebral injury, lesions, metabolic nutritional disorder, idiopathic. We have may be triggered by a specific stimuli such as flashing light, fever, loud noise, caused by an alteration in membrane protection that made certain neurons normally hyperactive and hypersensitive to change in their environmental. Nerve and distal neurons can be recruited into the seizure. Aura, drum suggests sense of an impending seizure. Those are basically alarm symptoms, okay, that the patient has. Generalized is the whole brain surface is affecting during the seizure involvement of thalamus and the reward system result of consciousness. Example: absence is a perimal. Absence seizures is common in the pediatric population. Atypical absence, myoclonic, atonic, clonic. Clonic is the grand mal, is the people that know patient on the floor, like having like movement the whole body. That's the tonic, and it's also called the grand mal. Status epilepticus, continue, continuing a series of seizures without recovery between episodes can be life-threatening. Partial seizure, normal electrical activity restrict one brain hemisphere, simple change in level of consciousness, motor, sensory, or autonomic system. Complex change in consciousness, partial with secondary generalizations, start as simple but advance to generalize. Diagnosis: electroencephalograms access electrical pattern of the brain regions. Laboratory study identify metabolic nutritional deficits, infections, and exposure to toxins. Lumbar punctions for CNS infections, CT MRI for structural causes. Seizure could be because of a lot of causes. Okay, that's why if you have a patient that have one seizure, most of the time you don't do anything. Okay, in the first event, the patient have another event, then you have to investigate what is the problem with that seizure. Okay, you have to do everything, including images. Treatment during a seizure: maintain airway from injury, document course of seizure, anticonvulsant medication, continue until no seizure at least 2 years, and then gradually withdraw. Not a cure. Avoid trigger surgery to remove of seizure palsy or neurostimulation. And we have question number one. Question number one: patient have a tonic-clonic seizure. What type of seizure did the patient experience? Remember, that's the one that everybody know, the most common one, tonic-clonic seizure. And the answer is grand mal. The other name, grand mal. Dementia syndromes associated with many pathologies characterized by progressive deterioration and continuing decline in memory and other cognitive change. Not be confused with delirium, abrupt offset with fluctuant becoming worse at night, disturbing consciousness, decreased awareness of the environment's incoherence, and hallucinations. You have to be very careful with delirium, okay? Dementia is a chronic condition, okay? It's a slowly, it's over time, years. Most of the time there are type of dementia that is really fast, but most of the dementia are with basically years. Delirium is acute and is common in elderly population that are in hospital. Elderly patient that you hospitalize the patient for any reason, okay? One of the most common reasons is infection, okay? UTI, urinary tract infection. You put the patient in the hospital and the patient start having problem with memory, worse at night, the patient get aggressive, and that's delirium. Type we have Alzheimer, most common, and vascular. We have more than those two types. Alzheimer's disease is characterized by the degeneration of neurons in temporal and frontal lobe, brain atrophy, amyloid plaque, and neurofibrillary tangles. Deficiency synthesis of brain acetylcholine cause remain unknown, although genetic variation, family history, increase for time, and environmental triggers suspect. Aging increased risk, behavior progress from forgetfulness to total inability to self-care. Depression and psychosis may be significant. Okay, let's go in. Okay, let's go back to Alzheimer. Uh, I'm gonna ask you a question. Nobody know what uh, aging is at risk to develop Alzheimer at early age, in the 40s. Okay, people with Down syndrome. Okay, you have to be very careful with people with Down syndrome because the gene that encodes for Alzheimer is in chromosome 21. That's why people with Down syndrome they could develop Alzheimer at 40 years old because normally Alzheimer start like after 60 years old. Okay, also have vascular result from single cerebrovascular insult, risk factors, stroke, hypertension, and diabetes. Clinical manifestation, early memory loss, especially short-term memory, long-term memory may be preserved. That's the same for Alzheimer. Okay, in Alzheimer, first you lost the short-term memory, and in progression of the disease, then you lost the long-term memory. But beginning, long-term memory is preserved. Okay, decreased ability to function at work and in social setting, anxiety, agitation. Clinical manifestations as the disease progresses increase difficulty with judgment, abstract thinking, problem solving, and communication. System for activity of daily living, ADLs, difficulty with eating and swallowing, weight loss, loss of bladder and bowel control, and eventually complete loss of ability to ambulate, personality and behavioral change. Diagnosis or management cause for dementia or delirium should be ruled out. Cell count, chemistry panel, thyroid function, especially vitamin B12, because that you get confused. Levels, syphilis, serology, CT scan, CT, MRI, lumbar puncture, mental status examination, talking drawing test, and the test of functional status. Treatment, early diagnosis, and intervention is key in the management of dementia. Earliest may be able to stay at home, later stage may need nursing home and assisted living. Acetylcholinesterase inhibitor, tracking, donepezil, galantamine, those are medication, rivastigmine, medication used for Alzheimer, indicated to mild to moderate Alzheimer's disease and vascular dementia. Not a cure. That's extremely important. There is not a cure. Okay? You treat to give a better life quality to the patient, but there is no cure. Methyldiaspartate receptor antagonist, memantine, indicate for the treatment of moderate to severe Alzheimer's dementia, block stimulation by neuroexcitatory transmitted glutamate, and care for the family and caregivers. That's why we have to exercise your memory. Always have to use your memory, okay? Because if you don't use your memory, you don't use your brain, then you are more at risk to develop Alzheimer's. And here we have question number 2. Neural threat potential on amyloid plaque formation are characterized pathology findings associated with which of the following disorder? And what is the answer? Okay, always that you heard amyloid plaque, Alzheimer, and fibrillary tangles, Alzheimer. Okay, amyotrophic lateral sclerosis, that's the famous Lou Gehrig's disease and the ice bucket challenge. You remember the ice bucket challenge was because of that disease. Parkinson's disease may be idiopathic, acquired, or drugs. Dopamine deficiency in the basal ganglia, substantia nigra, associated with motor impairment, Lewy bodies, difficulty initiating and controlling movement result in akinesia, tremor and rigidity, tremor occur at rest, and hand tremor exhibit rolling movement that's characteristic for Parkinson. Attempts to passively movement the extremity are met with bowel rigidity, general lack of movement, lack of facial expression that's common in Parkinson's, drooling, purpose left gaze, and absent arm swing. Treatment no cure, restoring brain dopamine level of activity by administration of dopamine precursor, dopamine agonist, monoamine oxidase inhibitor, and anticholinergic. Some therapy may be needed. Ablative surgical procedures may be held for motor symptoms. That procedure is just in some particular case Parkinson's. Cerebral palsy is the first group of crippling syndromes that appear during childhood and involve permanent, non-progressive damage to motor control areas of the brain. Damage in upper motor neurons that control voluntary and involuntary muscle movement. Symptoms remain for life. Classified on the basis of neurological signs and symptoms, with the major type involve spastic ataxia, dyskinesia, or a mix of one or more of the three symptoms. Etiology: neural infection of disease of the mother, mechanical trauma, the hen fed before, during, or after birth, exposure to nerve damaging, poisoning, or reduced oxygen supply to the brain. That's one of the most common causes. Treatments vary according to the nature of extensive brain damage. No cure. Muscle relaxants, anticonvulsant drug, orthopedic surgery, cast, brace, contraction, Botox for pain and range of motion. Remember that those patients have spastic paralysis, that is rigidity. If you put Botox produces flaccid paralysis. That means that you facilitate the movement. Abnormal accumulation of cerebral spinal fluids in the cerebroventricular system, hydrocephalus. Now we are talking about hydrocephalus. Normal hydrocephalus cause an increased volume in CSF. Type of symptoms: gait stability, urinary incontinence, and dementia. That's normal hydrocephalus, and is common in elderly population. Obstructive hydrocephalus is the result of an obstruction of the flow of CSF, blockage aqueduct of Silvio from premature closure before birth. Hydrocephalus, we have obstructing and communicating. Communicating hydrocephalus occur because of abnormal absorption of CSF, blockage of fluid from the subarachnoid space, or blockage of the subarachnoid villi themselves. In the subarachnoid space, we have the subarachnoid granulation. You have damage the subarachnoid granulation, then you produce communicating hydrocephalus, and it's common in meningitis. Medical treatment is limited. Obstruction may be corrected surgically. Most effective treatments ventriculoperitoneal shunts. That means that you communicate the brain with your stomach into the peritoneal cavity in an endoscopic third ventriculostomy, making a hole in the third ventricle to allow free fluid of CSF into the basal system for reabsorption. And we have question number 3. A patient has hydrocephalus from inability to absorb fluid from the subarachnoid space. Which type of hydrocephaly with the nerves observed documented on the chart? Okay, what is the answer? That's communicating. Okay, you have problem in the subarachnoid space, communicating. You have problem in the ventriculus, okay? In the cerebral, in the Silvius aqueducts, any of the communication in the ventricles, that's obstructive. Okay? Obstructive or non-communicating, because that's another classification. Communicating and non-communicating. Cerebral disorder, cerebellum, responsible for smooth, coordinated control of most actions, excitations, and inhibition of postural, reflex, and maintaining of balance. Cause abscesses, hemorrhage, tumor, trauma, viral infection, chronic alcoholism. Clinical manifestations: ataxia, hypotonia, intention tremor, disturbance in gait and balance. Treatment: identify and eradicate cause. Spinal cord and peripheral nerve disorder, we have MS, multiple sclerosis, spina bifida, amyotrophic lateral sclerosis, spinal injury, Guillain-Barré, and Bell palsy. MS is a chronic demyelinating disease of the CNS. You have to be very careful because multiple sclerosis, CNS, central nervous system. Guillain-Barré is peripheral nervous system. The primary effect on adults, autoimmune disorder that results in inflammation and ischemic sclerosis of myelin sheath covering nerve. Slowing progressive. Cause unknown, but immunological abnormalities, genetic and environmental factors suspected. Demyelination can occur throughout the CNS, but often affect the optic and ocular nerve and the spinal nerve tract. Nerve, most of the time, is the first sign and symptom in those patients, and also the most common sign and symptom, marked by exacerbation and remissions, exacerbated by heat, infection, trauma, stress, manifestation, double blurry vision, weakness, poor coordination, sensory deficits, bowel and bladder control may be lost, memory impairment common, diagnosis MRI. Remember that this is in the central nervous system, and the cell that is affecting the central nervous system is the oligodendrocytes, okay? And in the MRI, you are gonna see the oligoclonal bands. Okay? Treatment, no cure. If you don't have the diagnosis by the MRI, then you do the TAP, okay? The lumbar puncture. Treatment, no cure. Short-term steroid therapy may be helpful during acute exacerbations, and immune-modifying drug may slow progression of symptoms. Most of the time, treatment for MS is supportive. Spina bifida. Spina bifida is developmental, normally characterized by defective closure of the bony encapsulament spinal cord neural tube through which the spinal cord and meninges may or may not protrude. If anomaly not visible, spina bifida external obstruction of the sac-like structure, spina bifida cystic, and for the classification and to the stage of the neural involvement. Meningocele, meningomyelocele, meningomyelocele. Etiology, environmental factors, spatial lack of folate, and genetics. Clinical manifestation, sac-like cyst filled with CSF, spinal cord, or meninges. Primary neurological damage result in motor weakness and paralysis and sensory deficits below the level of the spinal defect. Diagnosis: prenatal, treatment, surgery. Amyotrophic lateral sclerosis is a progressive disease affecting both the upper and the lower motor neuron. That's the main characteristic of this disease because they have both manifestations, upper and lower motor neuron. Also called Lou Gehrig disease, cause remain unknown, genetic mutation possible. Weakness and wasting of the upper extremity usually occur, followed by impaired speech, swallowing, and breathing. Typically occur between 50 and 75 years old, men more than women. Multiple sclerosis is the other way around, women more than men. Clinical manifestation: weakness, atrophy, cramp, stiffness, irregular twitching of muscle, hyperreflexia in weak atrophied extremity. Diagnosis based on clinical signs and symptoms. Electromuscle, I don't remember this EMG because that's a test for the nurse conduction study, MRI, and serum laboratory testing. Treatment, no cure. This is a medication that basically is to give a better life for those patients, but it's not gonna cure the patient, okay? It's the only medication available. Spinal cord injury, problem of the joints, male for more likely, usually traumatic, unresolved of motor vehicle accident, fall, penetrating wound, usually gunshot, and sport injury, or may be compressed, transected, or contused. Mechanism of injury: hyperreflexion, hyperextension, compression. Secondary injury may be resolved from hemorrhage, swelling, ischemia, and inflammation. Spinal shock occurs immediately and is characterized by temporal loss of reflex below the level of injury, muscle flaccidity, skeletal autonomic reflex loss, in a spinal shock, reflex return from flaccidity replaced by spasticity. Neurogenic shock may occur after spinal injury because of peripheral vasodilation. Hypotension, bradycardia, and circulatory collapse can occur, life-threatening. High spinal injury can affect respiratory muscle, leading to ventilator failure. Autonomic dysreflex is an acute reflexive response to spastic activity below the level of injury. The circular stimulations and activation of the receptor below the injury are common stimuli. Manifestation: hypertension, headache, bradycardia, flushing above the level of the injury, and clammy skin below the level of injury. Removal of the offending stimulus, aggressive blood pressure management may be needed. Treatment: Appropriate stabilization of the spinal vertebrae may be accomplished surgical with internal fixation or external fixation and bracing. Cryogenic shock, intensive care, maintain oxygen and blood pressure. High-dose methylprednisolone may be used to decrease secondary injury, especially decrease inflammations. Intensive rehabilitation is required to maximize functioning. Guillain-Barré is an inflammatory demyelinating disease of the peripheral nervous system or the lower motor neuron disorder, also known as acute idiopathic neuropathy or polyradiculoneuropathy, cause of known infections, immunologic mechanisms suspect, spontaneous recovery usually occur. Classic manifestation: muscle weakness that begins in the lower extremity and spreads to the proximal spinal neurons. Progressive ascending weakness or paralysis. That's the main sign and symptom. It's also called progressive ascending paralysis. Okay? That's the main sign and symptom of this disease. Diagnosis: patient history, family physical examination, and nurse conduction study. Lumbar puncture. Treatment: supportive apoptosis, that's one of the medication, and immunoglobulin, that's another medication. Bell palsy. Okay, Bell palsy basically is paralysis of the cranial nerve number 7. Okay, the common etiology is a virus. And diagnosis: physical finding, MRI, CT. And treatment: the treatment for Bell palsy is this corticosteroid. Okay? That's the main treatment. Actually, the only one. Most of the time, the doctor prescribe acyclovir because the most common one is a viral, but the main medication is corticosteroid. Okay, we finish right here with chapter 45. Any question? No? Okay, you don't have any question. Let's go to chapter 47. It's really short. Finish the class for today. Chapter 47 is about pain. Okay? Physiology of pain, symptom of underlying problem. Diagnosis sections involve the physiology, mechanism of pain processing, divided into 4 stages: transduction, transmission, section, and modulation. Transduction is the process of converting from stimulus to neurological action potential at the sensory level. Non-sensory, nociceptors inner ending transduce noxious stimulus into the action potential. Chemical mediators alter the membrane potential of the pain receptor. Chemical mediators include sodium, hydrogen, lactate, histamines, serotonin, bradykinins, and prostaglandins. Enzymes prevents prostaglandin production by inhibiting the action of cyclooxygenase. Transmission stimulate nociceptor transmit impulse to the CNS by means of specialized sensory fibers. Primary sensory fibers include the A-gamma and the C. The A-gamma is large, and the C is small. Most sensory afferent pain fibers enter the spinal cord by way of the posterior nerve root, travel to the substantia gelatinosa, cell body of pain neuron located in the dorsal root ganglion. Transmission: pain signal transmitted by afferent fibers enter the spinal cord, the dorsal horns, synapses, interneurons, and then cross the core and project centrally in the anterolateral tract. Anterolateral tract has two divisions: neurospinothalamic tract and the spinothalamic tract. The first one carried the A and the second one carried the C fibers. Transmissions: lamina B, area for deferred pain. Many neurotransmitters and neuropeptides involved in synaptic transmission of the spinal cord level: substantia P, glutamate, GABA, cholecystokinin, and calcitonin gene-related peptide. Glutamate, lower brain center, cause consciousness, perception of pain, interpret pain quality. Brain can localize a pain sensation to a particular part of your body because of uh, nociceptors pathway in specific anatomic order in the core somatosensory cortex. Dermatome map useful for localized a source of neurological pain. Follow dermatome distribution because of spinal cord compression or trauma. Radiculopathy. Peripheral neuropathy do not follow dermatomal pattern. Carpal tunnel. We have question number 1. Which of the following statements about C afferent sensory pain fiber is true? Okay, this one, the answer is C. They transmit the majority of pain signals. Perception when brain interprets pain as painful. Result from neuroprocessing of pain sensation in the brain, influenced by awareness, emotions, previous experience, expectation, culture, physical status, pain threshold, level of pain stimulation required to perceive, pain tolerance, degree of pain of individual in swelling, willing to bear before seeking relief, pain expression, way in which the pain experience is communicated to others. Modulation, complex mechanism where the synaptic transmission of pain signal is altered. Modulation within brain, spinal cord, and endogenous descending pathway that originate from the raphe magnus in the brain go to the dorsal horn and release neurotransmitters that can inhibit synaptic transmission of pain signal. Modulations opioids have different effects depending on the type of receptor they activate. For type mu kappa sigma delta, gate-controlled theory, impulse carry, paralyzed myelinated tiny fibers, uh, stimulation of large of neurons could inhibit transmission of receptor impulse, and rubbing, pressing or shaking the painful area may reduce pain. Type of pain. Major subtype: physiologic pain, tissue injury have occurred, pathologic pain occur after tissue injury, but long-term change occur both within the peripheral and central nervous system. Change occur along somatosensory pathway from the periphery to the cortex. Pain can be significantly enhanced. Non-noxious stimuli may cause pains. Allodynia. Allodynia is common after a stroke. This change severe non-beneficial purpose. Classification, duration, source, location of the referral pain. Acute pain. Acute pain resolves from tissue injury and resolves when the injury heals. Usually lasts less than 3 months. Clinical manifestation: elevated heart rate, respiratory rate, blood pressure, pallor, sweating, and nausea. Pacing, grimace, crying, and moaning. Short-term therapy with non-opioid or opioid medication to provide adequate pain relief may prevent some type of chronic pain. Its become dependent of drug is minimal. Headache, classified according to the etiology factor: migraine, tension, cluster, sinus. Migraine results from dysfunction of the brainstem areas involved with modulation of craniovascular afferent fibers. May have migraine trigger. Clinical manifestation: unilateral throbbing with nausea, vomiting, photophobia, phonophobia, and lacrimation. Treatment: identify and avoidant trigger, antiplatelets, good alkaline NSAIDs, antidepressant, and beta and alpha blocker, and calcium channel blocker, pain medications. Chronic pain may be associated with disease process, lasts longer than the expected healing time, more than 6 months, increased peripheral reduction sensitivity, central sensitization loss at normal stage of responsiveness, increased gain of non-selective output. Clinical manifestation: generalized, associated with signs and symptoms of symptom activity, physiologic, such as loss of job, irritability. Depression may be a significant factor for individuals with chronic pain. Treatment in clinical with multimodal therapy. Fibromyalgia, etiology unknown. May many of many risk factors have been identified. Women affect more than men. Disorder pain mechanisms of the CNS characterized by widespread pain affecting all four extremities. Hyperalgesia, trigger or tender point. Associated symptoms such as sleep disturbance, insomnia, difficulty concentrating, fatigue, irritability, bowel syndrome, allodynia. Treatment: restoring sleep pattern, participating in regular exercise, and alleviating depression. Regular exercise is the main therapy. Gabaline used to target pain pathway. Cancer-related pain associated with cancer disease process may result from infiltrating of organs, compression of structure by the expanding tumor as a result of cancer treatment. Clinical manifestation: measure of symptomatic nervous system, eating and behavioral change. Treatment: multifaceted approach by use of potent medication, especially morphine, which is opioid. Adequate pain control is the major factor affecting quality of life. Exactly, because cancer people, you have to put those patients free of pain, okay, to give better quality of life. Result from tissue injury, neuropathic result from tissue injury in which the nerves themselves become damaged or dysfunctional. Constant aching sensation with intermittent charge, shooting, burning, and shock lighting may result from art-centered processing of nociceptive input, releasing norepinephrine onto nociceptive allodynia, hyperalgesia, atrophy affect extremity, fullness in affected area, dystrophy change, hair loss, medication, antidepressant, and anticonvulsant. Trigeminal neuralgia. Trigeminal neuralgia is a sudden, momentary excruciating along the second and third division of the trigeminal nerve, more common in women than men, may result from compression of the trigeminal nerve, but other structures of demyelination and irritation. Clinical manifestation is a charge shooting like electrical um, shock may be pain-free between episodes or complicated by dull achings in area. That pain is a really sharp pain that lasts from 5 to 10 seconds, and then you are free of pain. Treatment include anticonvulsants, surgical nerve decompression, and gamma radiosurgery. Diabetic neuropathy caused by damage of the large peripheral nerve, inflammation and demyelination, excess of smaller myelinating fibers, cause loss of inhibitory input from the spinal cord, on a process non-circumference bombardment. Clinical manifestation: burning pain, numbness, tingling, weakness, loss of vibration sense, and proprioception. Educate for food care and glucose control is crucial toward reduction for the condition. Antidepressants and anticonvulsants may help. Post herpetic neuralgia, reactivation of latent virus, herpes simplex virus that produce herpes zoster is characterized by burning pain that follow a dermatome. Always follow dermatomes. Patient pain that lasts persist pain that lasts for more than a week after the onset of skin lesions. Early use of antiviral medication, acyclovir, can decrease the risk of recurrence. Transdermal lidocaine, since cream, anticonvulsants, and other medications. Ischemic pain results from sudden or profound loss of blood from the tissue, decrease of aching, cry of aching, burning, and tingling, manage a improve blood flow, reduce tissue hypoxia, remove clot if needed, chronic ischemia, pain associated with atherosclerosis, intermittent claudication, pain with physical activity, and alleviated by rest. Treatment: weight loss, smoking cessation, exercise. Question number 2. And which information is correct regarding ischemic pain? And the answer is A. Activate the inflammatory response. Refer pain perceived in the area other than the site of injury. Example: the myocardial infarction that referred to the shoulder. Pain generalized referred to another structure in the same sensory dermatomes. Result: converge of visceral non-selective active with primary somatic afferents in the posterior horn of the core. Physiologic response to pain. Sympathetic nerve system activated during acute pain can lead to increased heart rate, respiratory, blood pressure, dilated pupil, precipitation, pallor, increased circulatory blood sugar, blood glucose. May be physiologically helpful in the short term, but becomes deteriorated in excess of long. Eventually, physiologic adaptation occurs and the observed sympathetic response to the pain abates. Pain in the young and elderly. Young and old often receive inadequate pain management. Infants have pain perceptions. Inadequate pain treatment in neonates and infants can result in persistent behavioral change and physical change in the CNS. Sections does not decrease with age, but communication and expression of pain may vary. Treatment modalities. In management, intervention can be directed at 3 points: interrupting peripheral transmission of non-sections, modulating pain transmission at the spinal cord level, altering the sections and integration of non-selective impulse in the brain. Interrupting peripheral transmission of pain. Often the first step in controlling pain. Bleeding help reduce tissue injury. Application of heat and cold alter blood flow, reduce swelling, NSAID, and local anesthetic. Modulating pain transmitted at the spinal cord. Continuous stimulation activate large sensory fibers that can block the central propagation of non-selective transmission in the interneurons. Transcutaneous electric nerve stimulation, massage, acupuncture, and so on. Question number 3, and question number 3 is using transcutaneous electrical stimulation to control pain. Nerve realize decrease pain by, and the answer is B, modulating pain transmissions at the spinal cord level. Almost done. Altering the pulsation and integration of pain. We work at specific receptor site located throughout the body, but are highly concentrated in the brain. Opioid analgesics have similar mechanisms of action, but vary widely in potency. Side effect: nausea, vomiting, respiratory distress. That's the worst condition. Tolerance, physical dependence. That's why you have to be very careful when you give opioid to the patient. Mild pain managed with non-opioid analgesics such as NSAIDs and or acetaminophen. Moderate pain with low-potency opioids such as codeine, and severe pain with morphine and fentanyl. Distraction: less able to integrate of pain experience with other competitions is present. Imaginary altered section of playful stimuli in higher brain center produce relaxing as well as analgesic relaxations. Conditioning response: increased blood flow. Biofeedback: increased endorphins. Conditioning response, and synapses. And we finish right here. Any question?